Hello, everyone. Today, we will be diving into a cornerstone of clinical nutrition and patient care, the acid base balance. Over the next minutes, I will explore how these balances, in concern to maintain the body's internal environment, a state we call homeostasis. Understanding this principle, the acid base balance, is absolutely critical for managing patients in any clinical setting, as imbalances can lead to severe and sometimes life threatening complications. So let's begin by establishing why this concept, the acid base balance, to clinical practice. Acid base balance. Acid base balance refers to the body's mechanisms for maintaining the concentration of hydrogen ion, which we measure by pH. The arterial blood pH must kept within a very narrow range, 7.34 to 7.45. The deviation in either direction can denature protein and disrupt critical metabolic functions. The body has three primary regulatory mechanisms that work different speeds. Number one, chemical buffer systems in the blood, like bicarbonate system, act almost instantaneously to neutralize acids or bases. Number two, the lung can respond within minutes by adjusting the rate of breathing uh, or to either uh, blow off excess carbon dioxide CO2 or retain it. Number three, the kidneys. The kidneys provide the most powerful long term regulation by excreting acid or reabsorbing bicarbonate. Though this response takes hours to days to become fully effective. When these highly effective regulatory systems are overwhelmed or fall, acid base disorders occur. Let's look at an overview of the four main types. In this table, there is the four major acid base balance. All acid base disorder can be classified based on two factors. The primary problem, is it metabolic or respiratory? And the resulting pH, is it acidosis or alkalosis? This gives us four main disorders. As you can see in this table, the respiratory disorders, the respiratory disorders involved primary disturbances in the PCO2, the partial pressure of carbon dioxide. Metabolic disorder involved involve a primary disturbances in bicarbonate or HCO3. The body then tries to correct the imbalances with an opposing action, which we call compensation. For example, in a metabolic acidosis, the lung will compensate by hyperventilating to lower the PCO2. This table is a great summary to keep in mind as we break down each disorder. So let's start with the metabolic acidosis. Metabolic acidosis occurs when there is either an accumulation of acids in the body or an excessive loss of bicarbonate. The classic example include diabetic ketoacidosis, where keto acids build up, or severe diarrhea, which causes a large loss of bicarbonate rich fluid. The diagnosis is made by seeing a low pH and a low bicarbonate level on the blood gas analysis. Clinician will then calculate something called the anion gap to help narrow down the specific cause. The body's immediate compensatory response is respiratory. Patients will often exhibit deep, rapid breathing, known as Kussmaul respiration, as the lungs work hard to exhale as much carbon dioxide as possible to rise the pH. The opposite of this condition is logically called metabolic acidosis. So, metabolic alkalosis. Sorry. Metabolic alkalosis is characterized by high pH and high bicarbonate level. This can be caused by an excessive loss of acids, most commonly from prolonged vomiting or gastric emitting, which removes large amount of stomach acids. It can also be caused by administration of bicarbonate or the use of certain diuretics. The body's compensation for this is to try and retain acid. The respiratory system does this by slowing the breathing rate, a process called hypoventilation, in an attempt to retain the carbon dioxide and lower the pH. Now, let's shift our focus for metabolic disorder to those that originate from the respiratory system, beginning with respiratory acidosis. Respiratory acidosis is caused by any condition that impairs the lungs' ability to get rid of carbon dioxide, a state known as hypoventilation. When you can't exhale carbon dioxide, the CO2, effectively, it builds up in the blood, combines with water to form carbonic acid, and dives the pH down. This is commonly seen in patients with chronic lung disease like COPD or emphysema, or in case of acute respiratory depression. The diagnosis is a low pH with an elevated the P carbon dioxide. The compensatory response comes from the kidneys, but it is slow. Over several days, the kidney will increase their reabsorption of bicarbonate to help buffer the excess and bring the pH back to where normal. Conversely, if ventilation is excessively increased, we see the opposite condition called respiratory alkalosis. Respiratory alkalosis occurs when a person is hyperventilating, breathing too fast or too deeply, and exhaling carbon dioxide faster than the body produces it. This blowing off of carbon dioxide lowers the acid level in the blood and rises the pH. This is often caused by anxiety or panic attacks, but it can also be a sign of serious underlying conditions like pneumonia, head injury, or pain. The diagnosis now is highly or high in pH with low in P carbon dioxide, and the kidney will compensate by increasing their excretion of bicarbonate, though again, this is a slower process. This is all in the acid base balance that already discussed it. So, thank you for your attention and see you in the next lecture. Goodbye.